Welcome, everybody. We're just admitting everybody in. Okay, should we get started?
Let's get started. Okay, welcome everyone on this National Anosmia Awareness Day to the Smell and Taste Association of North America's hopefully annual stakeholder workshop. Today we're talking about patient engagement in advancing chemosensory research. We have a few guidelines, but before we start, I'd like to introduce the main speakers that you'll be seeing today. I'm Susie Brenner. I'm the project lead for this contract, and I have a little bit of a background in nonprofit management, most recently in seniors and senior health and wellness. I'll let everyone introduce themselves when it comes to their turn. But as you can see, we have Pamela, who's one of STANA's co-founders. We have a patient we have a patient engagement specialist who's going to be speaking to the bulk of our meeting. And then we've got our patient cohort liaison, Sarah, and two of our patient partner cohort members, Kurt and Kurtisha. So thanks everyone for being here. We have everybody muted automatically. We'd appreciate if you would stay on mute, obviously. But we do have the chat. If you have something that you would like to add or ask a question or something to include, we are monitoring the chat and we'll certainly be as interactive as we can. And we hope this will be a nice informative workshop for everyone. So first and foremost, for those of you who do not know, STANA, or Smell and Taste Association of North America, was established in 2021. The overall vision is a world where taste and smell are valued as essential to health, safety, and wellness. Some of the key pieces of the mission are to be patient-led and patient-focused, putting the patient experience at the forefront of the work of the organization. And of course, being compassionate and collaborative. We work with partners who share the same commitment to empowering patients, researchers, and healthcare providers. And we always aim to be transparent, enabling the information that we gather and learn to be shared to make sure it's reliable and evidence-based.
Thanks, Susie. I'll take a moment just to introduce myself. As Susie said, I'm a co-founder of STANA. I'm an acquired anosmic, and I lost my sense of smell over 15 years ago. I went to a lot of doctor's visits, trips to taste and smell clinics, all to try to find treatments and a cure, but really to no avail. And it was a lonely and isolating experience. Being able to help build this community of people with similar lived experience has been really meaningful to me. We're very appreciative of everybody who's here today. We have a lot of clinicians and researchers and advocates who are allies in this effort with us. And we have a lot of patients who are united by our shared lived experience in terms of what it's like to live with smell and taste dysfunction. At the same time, we're a very diverse population with different types of dysfunction and many different causes. And this discussion today is intended to be inclusive of our diverse patient community that STANA represents. We hope it's a productive presentation. As a small and young organization, we're only a few years old. We're heavily reliant on individual donations, but we have been able to further our mission significantly because of two contracts with the Patient-Centered Outcomes Research Institute. And in 2023, we were awarded a contract that was specifically to help us expand capacity for PCOR, Patient-Centered Outcomes Research, and CER, Comparative Effectiveness Research. We're going to talk a little bit more today about what that entails. In this climate of kind of uncertainty around government funding, I wanted to just note who PCOR is and how they're funded. They're a nonprofit independent organization. They were actually funded in 2010 as part of the Affordable Care Act. And interestingly, they receive funding from a general fund of the Treasury Department. They're not reliant on funds from an agency. And they also receive funding from something called the PCOR fee. And it's a fee that was, again, created through the Affordable Care Act that is applied to private health insurance and self-insured plans. And that fee goes, 80% of it goes to PCOR and about 20% of it goes to the Department of Health and Human Services. So I just wanted to sort of give you guys a quick summary of what we're going to cover today. There's really 4 key objectives today. First, we want to talk about patients' priorities for research. We'd all like to have more chemosensory research and more funding for that research, but patients also know what matters most to them and what topics they believe should be prioritized. We'll talk about why clinicians and researchers should engage patients as partners, not as mere subjects in their research. And then we'll discuss in detail what comprises PCOR and CER and what PCOR funds, and then how engaging patients can lead to more effective outcomes. And we'll tell you about STANA's newly formed, I say newly formed, although it's now a year old, patient partner cohort. And we'll introduce you to a few members of the cohort who recently completed work on a project.
So we'd love to know who's here with us today. I know when you registered for the Zoom meeting, we asked you where you were located and why you were interested, but we'd love for you to share it in the chat as well. Are you a patient? Are you a caregiver of a patient? Are you a researcher, a clinician, just an interested party? And of course, how long you've had an interest in smell and taste, what brought you to the workshop, and of course, why do you think patient engagement in research is important if it's something that you know about? This can help inform us today, but also for future workshops and things that we will do. So we welcome your feedback, whatever it is that you want to share. So why are we here? Well, we all have this shared goal and it's important for everybody to understand that smell and taste research is grossly underfunded in the United States. So the National Institute on Deafness and Other Communication Disorders, or NIDCD, this is their budget. This pie chart is their budget for fiscal year 2024. You can see 58% was dedicated to hearing imbalance, 30% voice, speech, and language, and only 12% to smell and taste research. And this is astonishing to me, considering how many people lost and had distorted sense of smell and taste from COVID. But those are the numbers. So this is why we do what we do, and we need to really join forces as patients, clinicians, researchers, the whole industry, to get together and advocate for more funding for research.
So when we think about research, we want to prioritize what's important to patients, and we know what research topics are important. How do we know? Because we ask patients. We asked them in 2022 as part of our first PCOR funded project. We partnered with the Monell Center and the Otolaryngology Department at Jefferson Health, and we conducted the first USA smell and taste patient survey. The participants had a range of smell and taste conditions and were geographically dispersed with representation from all 50 states and the District of Columbia. The turnout was tremendous, 5,500 respondents, 2 weeks. And this was a 60-question survey that took 15 minutes to complete. So it was a commitment. But part of the incredible turnout was due to our timing on the heels of COVID, when many people were suffering with a range of taste and smell dysfunctions with little access to information or care. But we also learned the patients were frustrated. They felt their smell and taste dysfunction was overlooked and underappreciated. They felt dismissed by clinicians when they sought treatment, and they were disappointed by what they perceived as a lack of education about these disorders. So when we asked patients, would you be willing to participate in research? overwhelmingly 90% said yes. I mean, that's hard to get a 90% response rate on a question. But this group of patients was all in. And we even went and specifically asked patients about the types of research that people would be interested in participating in. 81% said, non-pharmaceutical or non-surgical treatments. 79% wanted to work on participate in research that looked at the risk factors for smell and taste, or the mechanisms causing smell and taste loss or dysfunction. 69% were interested in clinical trials, and 43% said that they would work on a project for a surgical treatment solution. To understand what most affects patients' lives, we asked survey participants to identify the things in their lives that were most impacted. They could select more than one, and then to show you here today, we've color-coded them into sort of related groups. And you can see that if you look at the blue bars, that there was definitely a lot of focus around eating-related topics. Those were sort of most frequently identified. And that includes cooking, nutrition, and appetite. That was followed by factors that affect relationships and intimacy, and then mental health, followed by mental health and memory, followed by hygiene, and then safety. I think the safety one is one of those things that you probably don't think about until you've been endangered by a gas leak, like I have actually twice, or by fire, smoke, or contaminated food, until it actually happens to you. So I think it is probably more important than it appears on this chart, but not impactful on a daily basis to quality of life of our respondents in the survey. We took those those things into consideration, but then we also went and asked people, okay, given those issues that are affecting your quality of life, what do you think are areas of support that are sort of most important to you? And so we, for this chart, we just wanted to show you, this is really the top 6 things. There was a longer list of things, that areas of support that were important to them. But we've also grouped together when the participants were ranking what was most important, and very importantly sort of added those 2 numbers up to show you how patients rank these things. And effective treatments was got the highest ranking, probably not surprising to this audience. Better and more medical community knowledge, 81%. And I sort of touched on that earlier, where patients were frustrated because they felt like the clinicians they were seeing were not educated on these topics. They also told us better diagnostic tools, and that includes testing. Mental health support across the board. Our patient community would like to see more resources on mental health support. Lifestyle strategy for compensating and coping with these conditions, and more public awareness. So these are really the top 6 that came to light. We took those priorities, and then we actually sat down with our patient cohort and broadened the topics a bit to encompass a wider range of healthcare concerns. So these are areas of research priorities that we're going to continue to hone and look at and better define over the next few months as part of this project, as we work our way forward. And our goal is to develop a lay research agenda that can guide us, but also help inform clinicians and researchers about the areas of strategic importance to patients, which are also represent the greatest areas of benefits to the patients. So we hope that our agenda will be a great tool for clinicians and researchers as they think about what research to engage in. Now we want to talk about effective engagement with patients. So just to level set here, as we're talking today, we're talking about, when we're talking about patient engagement, we're not talking about the traditional idea of patients as subjects. By all means, that's really important. And as you can see from our earlier survey results, our patients are willing and want to be subjects in clinical research. We want more clinical research. But today we're talking about engaging patients as partners, sitting at the table with you in the design and the implementation of these research projects. And I'm speaking to the clinicians and researchers. But empowering patients in scientific and medical research is increasingly accepted as a way to enhance the practical relevance and the quality of health-related research. There are quantifiable benefits to patient engagement, which we'll demonstrate for you today. But from a qualitative standpoint, engaging patients as partners improves the decision-making and the applicability of the outcomes of the research. I mean, patients can help with priority setting by identifying what's most important to patients. It can help improve study design to be more accessible and feasible for patients. They can help boost recruitment, support the gathering and analyzing of data by bringing to light how patients think. They can help direct the dissemination of information to sources that patients rely on. Open access, for example, is really important to patients because we want to be able to read the results of this work. They can help craft lay language and play an active role in preparing findings. And, the idea of engaging patients in this way, this can be a win-win situation for patients, clinicians, and researchers. But to have successful engagements, it is a collaborative team effort.
And to make that collaboration a little bit simpler, perhaps, or clearer, STANA has developed these guidelines, this promising practices for including patients or in the research, patient-centered research. So I'm not going to read through all 9 of these, but some key points. One is to really include patients from the beginning. Help them incorporate the principles from the start. Secondly is compensating, budgeting, putting in the budget there, some compensation for the patients. They are a valuable piece of this. There's a phrase that I've learned through working with STANA that I love, that the patients are experts in lived experience. They bring an expertise to the table that a clinician who doesn't live with anosmia cannot bring to the table, and it's very important. And then moving through the numbers, things like publications, to make sure that a layperson can read the study or the outcome and understand what's going on. And then there's the piece, of course, of intellectual property, including the patients all the way through to that white paper or whatever the outcome is in the end. At the bottom of this slide, you'll see that there is a way for you to get a full copy of these promising practices. You go to thestana.org/patient-engagement, and you can request a copy. We'd be happy to get that to you. We're not reinventing the wheel here. Patients as research partners has been going on now for a while. The institutions over on the left have been doing it, including the U.S. Food and Drug Administration. And some of the organizations listed on the right, on the right, are just some of the organizations that have been doing this. Beacon stands for Bladder Cancer Advocacy Network. For 20 years, they have had a patient partner cohort, patients that are living with bladder cancer that can help in research. And also Michael J. Fox Foundation, Parkinson's Foundation, these others, they have been doing this. We just want to bring it to the chemosensory world. And here are some of our patient cohort members that are on this call. And as I said, some have been with us for a year, some have been more recently trained. And we just wanted to thank them publicly for the work that they've done, learning about the research, and hopefully participating in studies coming soon. So next, I want to introduce Sue Schrant. She can talk a little bit about herself and how you really apply patient-centered outcome research and CER into chemosensory research. Thank you for being here and bringing your expertise.
Thanks so much. Thanks to everyone. It's great to be with you. I'm Sue Schrant. My background is in patient engagement. I've been doing this work for a long time. I am a patient and a patient advocate, not from the chemosensory world. I actually belong to the autoimmune disease and rheumatoid arthritis community. But I do now have lived experience with smell and taste loss that actually began as I was working with STANA on the project that preceded this one, developed both smell and taste loss from COVID, and I still have ongoing changes to my taste. So it was a sort of an ironic occurrence to be working with this wonderful group and then to experience just a little bit of what this community goes through. I actually had a role at PCOR, the funder of this project, as the Deputy Director of Patient Engagement many, many years ago when PCOR was first created. And so for obvious reasons, really love these types of projects, and it's been a real privilege and honor to work with this group. So I'm just going to walk through a little bit more about sort of the nature of the research and how we really do all the things that you've heard about. How do you put those wheels into motion? So PCOR, Patient-Centered Outcomes Research, is what PCOR funds. And it's really pretty simple. The idea is assessing benefits and harms of healthcare interventions to really help patients and clinicians work together to make informed decisions. This is research that really pays attention to patients' preferences, their autonomy and needs, and focuses on outcomes that you care about as a patient community. It can occur in a variety of settings. We'll talk a little bit about the specific type of research, comparative effectiveness research we'll get to in a minute, but I'll talk more later about how truly diverse their portfolio is at PCOR, that you can really design research in a number of ways that still honors the goals and the principles that PCOR has laid out. And then finally, it really is about being realistic. And so we want to aim for those great outcomes, but understanding that the research itself has to be done in a way that makes sense and is feasible for the community, and that the answers we get have to truly be implementable. It doesn't help anyone if we end up with an answer that's unrealistic because it's too expensive, it's rare, it's not going to come to fruition soon enough. So there's a lot of realism in what PCOR funds. So we can go to the next slide. So sort of in that umbrella of PCOR, of Patient-Centered Outcomes Research, there's another acronym, Comparative Effectiveness Research. And that very simply just means that everything PCOR funds has to be a comparison between two or more options. And in the case of the research we're looking at for the chemosensory world, this could be the best option in testing and diagnosis or in treatment. It just has to be what works best to solve whatever the problem is that we're aiming to solve. So we can go to the next slide. Sometimes it's easier to understand what PCOR does fund by thinking about what they don't fund. That's why we wanted to have this slide and spend a minute here. They do not fund just descriptive or basic science. So nothing that's truly bench science looking for, biologic molecular causes, but also not just understanding or describing the problem. They really want to fund what is solution focused. And so it's kind of moving on to sort of down that pipeline so that you can get to answers that are implementable. But sort of ironically, they also don't fund research that creates new things. So you wouldn't be able to develop new drugs, new devices, new techniques, because they want to compare whatever is currently being used to each other to find what will ultimately work best for patients, however, for whatever you're solving for. The thing to think about here is that this could still be an important piece of your research arc if you did develop something new, if you developed a new therapy or a new diagnostic test. What you would eventually want to do as sort of your validation is think about a PCOR funded study to compare existing technologies or drugs or tools with whatever that newly developed tool is, because that's the perfect kind of comparison. Then we can see, does this new thing work better or better than what already exists? And so we only describe this so that you have a clear sense for what is fundable and what's not fundable. Okay. So we can really illuminate probably most effectively the way this type of research would look in the chemosensory community by just going through some some research questions that really originate from the survey data that's already been collected. I mean, this is a treasure trove of data. It's very rich data, incredibly well-powered survey, as you heard. So for example, a classic CER question would be, which treatment for smell and taste loss or distortion works best? And what's really interesting is that the research results have already sort of teed up some pretty compelling questions and maybe concerns. And you see here that patients indicated that the treatments they most commonly received were nasal steroids and smell training. However, when patients were asked to report what they found to be the most effective, those things did not align. So that already sort of lays out a platform for, we need to do some work here. Let's look at some comparative effectiveness research that truly gets us to the best treatments so that that data, that learning can be disseminated and those treatments can be more widely used among patients so that they can get the relief they're seeking. If we think about diagnosis, it's the same kind of question. What contributes to a more timely or accurate diagnosis? One of the things that emerged from the survey data was that there was sort of a greater likelihood, and you see here, if you saw an ENT, you were 5 times more likely to get a diagnosis than folks who didn't see an ENT. The majority of people were talking about seeing family practitioners, and they felt that they were more knowledgeable about smell and taste dysfunction and might have a better odds of having an officially documented diagnosis. So again, the survey data is incredibly valuable and helpful, but if we could do comparative effectiveness research that really sort of just in very black and white shows this is the best pathway to get a diagnosis, more people are likely to get an accurate and timely diagnosis if they follow sort of this this protocol, if you will. That's the kind of information that could be widely disseminated and really benefit a tremendous number of patients. So comparison at what level is a really critical piece of understanding the whole enterprise of PCOR funding. The most traditional concept, and in fact, what most of the examples I've already provided kind of focus on, is that real A to B comparison. That's what most people think of when they think of CER, that it might be pill A to pill B, or diagnostic test 1 to diagnostic test 2. And that's certainly a large proportion of CER. But your level of comparison could be at a very high difference. So it could be different types of providers, as we just talked about with diagnosis, but it could be differences between healthcare systems. You could do a study looking at different patient populations as the comparator for a particular tool or I apologize, treatment. So don't kind of get, don't feel narrowed that it would have to be pill to pill or technique to technique. It could be quite high. And if you look on the PCOR website, you can see the types of things they've funded. And there truly have been, I want to say there was even one Medicaid system versus another Medicaid system for a particular study. So you can be quite creative and expansive with how you define and articulate the comparator in a study. And then again, it's just always helpful to think about kind of the converse. So when we're talking about comparative effectiveness research, it needs to be solutions focused. We want to know what's best. One of the things that the survey has already sort of answered for us is what kind of information do patients seek? Where are they going to find information? Where are they connecting to one another? And that would be a descriptive study. What we can do is move on to the next step. Let's talk about what kind of information and education actually leads to optimal outcomes. Is there some sort of correlation between where you go for data and how early you get diagnosed, or how quickly you can move to effective treatment if that's an option? So it's just about shifting the orientation from describing the problem to focusing on solutions. Kind of just getting to the nuts and bolts of how this works. So you've heard now this concept several times. The idea is that patients have that firsthand lived experience that nobody else has. And that's why they're such critical partners They can be leaders, they can be advisors, they can partner in any number of ways. And it's important that you sort of leave here today with this in mind, that there's no piece of the research process that patients can't be involved in. Some parts might be easier to facilitate than others, but they can play a role in any conceivable step of the research process. And in PCOR language, they usually break it down into three main pieces. So planning or designing the research project, conducting the research, and then sharing and implementing research results, and anything that might come before or after. But that's the idea, is truly any part. And ideally, they are involved from beginning to end and back again. So just a real partnership. And I'm going to go through just a couple examples very quickly. I find that learning by analogy tends to be quite helpful, or learning from example. So I'm taking some examples from the PCOR kind of portfolio, stepping outside of chemosensory world for a minute. We're going to start with just an example of how patient partners, in this case, parent partners, improved a study protocol. So this was a case in pediatric appendicitis, and the comparison was the traditional removal of an appendix to use of a particular antibiotic and watchful waiting. And you can imagine this is an emergency situation. As a parent, you're taking your kiddo into the emergency room or emergency department with pain and other symptoms. And now you're being approached to be in a randomized study. So you will not have a choice for whether there's surgery or this watchful waiting. And no parent partners were involved in the original creation. That's not a typical PCOR. I'm not sure how that happened, but in this case, that somehow slipped past. The parent partners were not involved in the original development of that recruitment strategy. And so what was happening was the family would show up, and sort of whomever was available at the time would quickly run through, hey, we have this study going on. Would you be interested? Just sign here. You're going to be randomized. You'll either get surgery or get the antibiotic. And you may or may not be surprised to hear that they did not get a lot of bites. So not a lot of people signed up for this. So they were really struggling with this low recruitment. And as many of you may know, low recruitment or failure to recruit at all is often the death knell for clinical trials and for other clinical research. So they took it to the parent partners and said, oops, we think we might have done something wrong. And the parent partners said, well, this is a very difficult time. You're panicked. All of these parents had been through appendicitis with their kids. So they said two main things they felt would really change the game. So first is, the only person that could make me feel comfortable as a parent, flipping a coin or allowing the research team to flip a coin and choose either surgery or watchful waiting, is if a surgeon told me it would be okay to not have surgery. Surgeons like to do surgery. So if I could have a surgeon say, I would feel comfortable doing this. We think there's equipoise. We think that they're equal, but we want to know if one is better. That would help. That would help me feel more confident. It also needs to happen in a quiet space. I mean, the emergency room is loud and frenetic, and there's just anxiety coming out of the walls. Could we pop into either an exam room with a door that closes, or somewhere that I can just think for a minute and give me time to have that conversation with the surgeon? And when they implemented those changes, they saw an immediate uptick in recruitment rates. This example is probably one of my favorites, because the thing that I have seen the most profound benefit in is patient partner involvement in data analysis. And maybe that's because it's an area that it's really hard to convince people that you could involve patients, especially if the patients have no statistical experience or didn't come from a medical field or medical background. But that's actually a benefit in this case, because they can provide this context from that lived experience that isn't sort of tainted by classic scientific or medical or statistical training, if that makes sense. So in this case, this was a rheumatoid arthritis study that I was involved in. I led the patient engagement on this. So we were looking at treatment patterns. We wanted to understand how quickly patients were cycling through their therapies. And our data source, for better or worse, was insurance claims data. So you had just, reams and reams of Excel sheets with clinical or with claims data. And when the data scientists took a first pass, they were actually trying to clean it up a little bit so that we would be able to understand what was there. When they just took a first pass, they were very worried because they saw incredibly erratic treatment patterns, people stopping and starting and restarting, and one drug was retried 4 or 5 times. And so they thought, you know what? We think this data is corrupt. We think we must have a bad file or a number of bad files. But before we do anything, before we scrub it or ask for a different trove, let's take it to the patient partners and just have a conversation about it. And we said, not so fast. Let us take a look, and we'll tell you what we think. And sure enough, from our perspective, the data was incredibly clean and accurate. We know that patients stop and start therapies all the time for infection, for surgery, because of side effects, because of insurance delays or stalls. We know that sometimes you get to the end of the rope and you have to try the same therapy again and hope that maybe this time it works better. So all of that dynamism was very familiar to us. And if you think about what might have happened if they didn't have patient partners in the room to review that data, they would have just chucked it and we would have missed really valuable data. I mean, we essentially answered the research question without even getting all the way through the research. And that was that the treatment patterns are incredibly erratic. So truly, there's no step of research that patient partners can't be involved in. Okay. And then lastly, I am not a numbers person, but I've been doing this work for a while, and this slide always gets a lot of raised eyebrows, so I love to include it. This was an economic analysis done by researchers Ken Getz and Bennett Levitan. And this is, I will say, this is particularly looking at clinical trials, mostly in drugs, could be devices, but they were really focused on drug clinical trials. But the learning is the same and the application is the same no matter what type of patient-engaged research you're doing. So this was looking at if you spent $100,000 to embed patient engagement in the development of your clinical trial protocol. They calculated that the return could be even over 500-fold that initial investment. And the reason for that is you're preventing the need for late-stage protocol changes. I mentioned that recruitment kerfuffle from the PCOR example. If you have something like that in a clinical trial, you might get shut down. You might not be the trial might fail because of lack of accrual. It's also things like the connection to the patient community, how the protocol is written, the feasibility of the study might make it more attractive. And if patients are aware, if there's a group that can say, hey, we helped build a clinical trial protocol, that establishes a bit of a trust factor that I think, oh, well, I see myself reflected in that protocol. I know that people from my community helped sort of pave the way and make it as feasible and accessible to me as possible. So there's a number of reasons, and there's so many we don't have time to go through them. But if you are interested in the true dollars and cents, it literally is an investment that pays itself back many fold. And not to mention, it's just sort of the right thing to do. So I love to include this slide. Okay, and I will turn it back over to my colleagues to talk more about this fantastic patient partner cohort.
Thank you so much, Suze. I'm going to turn it right over to Sarah Sarkowski, who is our patient representative. She represents our patient cohort and is going to hold a little interview with 2 of those members. So Sarah, take it away.
Yeah, like Susie said, my name's Sarah Sarkowski. I do have hyposmia. I lost my sense of taste and smell about 13 years ago, but I don't really have a cause for it. And I am the liaison for the patient partner cohort. So I'm going to talk a little bit about that right now. It's comprised of a dynamic group of people with different etiologies of smell and taste dysfunction who are committed to driving change in chemosensory research by participating in training. We share experiences, collaborating with patients and researchers, and representing STANA, not as research subjects, but as participants in design and implementation of the research projects. Our cohort was launched about a year ago. First, we had a kickoff workshop in February of 2024, inviting people to learn about the cohort. We had about 70 plus RSVPs. In April, we had a kickoff meeting for 30 attendees of those who were interested. Since that time, we had about 17 cohort members who've completed 4 hours of PCOR fundamental training, attended and contributed at meetings in June, September, and then January of this year. We had our first pairing of cohort members with the Monell Center research team, which extended from September to January. So STANA serves as the cohort facilitator and matches cohort members with research partners. So if you're a researcher and you're interested in collaborating with members of our patient partner cohort, you can do so by requesting and reviewing the Promising Practices Guidelines. Email STANA at info.thestana.org with the description and details regarding your projects. And then as a facilitator, STANA maintains contact throughout the project. Upon completion of the project, then the researchers and cohort participants are requested to complete a feedback survey. So the next slide has sample questions asked of the research team, and then some of their answers, and then also of the cohort members who participated and some of their answers. Okay. So 2 of our cohort members that partner with researchers are joining us, Kurt and Kurtisha, to share their experience. So I'll let Kurtisha and Kurt introduce themselves and then answer our first question of why did you decide to join the cohort? Kurtisha, you want to go first?
Yeah, I'll go first. I'm Kurtisha. I acquired anosmia about 4 years ago after a pretty severe COVID-19 infection. And what kind of prompted me to join the cohort was just wanting community. I felt really alone in that experience, and in some ways still do because like all of us live around the country. So we do get to connect, but that connecting is difficult at times. But I wanted to join for community just to like have that support. But I also recognized pretty early on with my background in mental health and counseling that a discussion around like wellness and mental health and how the quality of life is impacted, that was important to me in terms of patient engagement and research. But I also realized and knew from experience that folks with historically excluded identities are often left out of the research conversation and research design, specifically Black, Indigenous people of color. So given that I was now experiencing anosmia, I wanted to be a part of what I hope to be more patient engagement, and specifically those with different marginalized identities being a part of that too. And I think a value of patient engagement is in the term, it's patient. Like we have that lived experience, but also connections to the community in ways that researchers might not. And so I think being able to provide that perspective, as well as, I don't know, I guess just be a part of the design and a part of how the process goes all along. I think that's important when you consider the solutions are they gonna impact patients. So I think that voice should be represented all throughout. I'll turn it over to Kurt.
Hi, can you hear me, Sarah?
Yep.
Oh, hi. My name's Kurt Winnicky. I had a mild COVID infection back in 2021, and I only experienced mild symptoms, and they were only olfactory related, only smell and taste related. I didn't have any other long COVID symptoms at all. So I've had parosmia for over 3 years now. It's been gradually improving over time, very slow improvement. kind of like watching your kids grow. But you know, smell and taste disorders do over the months and over the years after year, with altered senses, which is parosmia, it does take a serious toll on your mental health. And I know for me it did. And the reason that is because with vision and hearing, it goes to a different part of the brain. It goes to maybe the analytical part of the brain first, but with smell and taste, those senses go directly to the emotional part of the brain. And so you're dealing with that on the mental health side. And also with long COVID, you're dealing with the unknown, you know, of a novel virus and when you're going to get better. So it's hard, you know. Parosmia is probably the hardest thing I've ever done. And I'm a little bit older, you know, I'm 63 now. So I've done a lot of hard things in my life, but parosmia has definitely been one of the hardest things I've ever done. The reason I decided to join STANA's patient cohort was, well, a lot of reasons, actually. The main thing is I just want to help people. I actually started a local Indianapolis indie parosmia support group on a meetup. You know, so I paid money out to start a meetup, and it was hard to get it off the ground, but you know, I just wanted to be there to support other people who are going through smell and taste problems from COVID. And I also want to help, you know, researchers. I want to help funders like the NIH. And I also want to help these new organizations that have come in about, like the National Smell and Taste Center or the University of Virginia Smell and Taste Center. These are brand new organizations. I want to help them. So for me, you know, getting involved with research is good for my mental health because it feels like I'm at least doing something, you know, to help myself rather than nothing. I also want to be a representative for parosmia. It's a very difficult condition to deal with, and also help raise awareness about lived experience of chemosensory disorders. I think there's a lot of value in patient engagement in research. It can be a great partnership. The partnership between a patient and the researchers is invaluable because, you know, we need you and you need us. And also for the researchers, the research team and the research organizations, you get to have another expert on your team, right? We are experts in the condition that you're studying. So it's going to be great to have us on your team. So as patients, we have insight that no one else has about how this condition plays out in real life. And in becoming experts in researching our own condition, we've gained huge insights about the population, you know, whether it's anosmia or parosmia or others. You know, we spend a lot of time researching our own condition over years, and from social media, we've gained a lot of insight about not only us, but the whole population that you're studying. And then lastly, I wanted to give you kind of an analogy. If you're a scientist or a researcher and you were given, you wanted to design a trip to the moon. So you want to design a modern spaceship, lunar module to get to the moon. And you have to design the spaceship and the module and the controls and everything. In order to do that, you know, it would be great to consult with astronauts first because they're the ones that are going to be flying to the moon and landing and walking around, right? So if you're going to design a trip to the moon, you would want to consult with astronauts, and patients are like astronauts. And it's kind of ironic because when you live with smell and taste disorders, it can be kind of an isolating, lonely experience. So sometimes it feels like we're astronauts. So that's all I had.
Okay. And I know you both had good experiences collaborating with the researchers on your project. I just hope in the future we could collaborate and other members of the cohort can collaborate with researchers on other projects. I don't know if you want to open it up to any other questions.
Yeah, if anyone has questions for either of our patient cohort members that are right here, or other questions that you can include in the comment feature, we will try to answer them.
There was a question for Kurt and Katisha, just about, you sort of touched on this a little bit, I guess, some things you're saying, but in terms of like the technical aspects of the research project, because you're not chemosensory scientists, how did you find that when you were working on the projects? Did you find it confusing, or how did you handle that aspect of the project?
I think
Go ahead.
oh, Kurt, are you gonna go?
Yeah.
Okay, go ahead.
Yeah, I'm an engineer by trade, so I already have a kind of a research technical background. But so for me, it was very technical, but I was able to read through it and understand it for the most part. And hopefully I helped them out in my feedback.
And for me, I have experience in research, just not this side of research. So it definitely was a little bit more of a learning curve for me. But like Kurt mentioned earlier, we're already doing that research and looking into what impacts our diagnosis as well. And so that helped me. Like, I had a little bit of a foundation to start with, but what was really helpful was having kind of a pre-conversation with the research team before actually diving into the more technical side. Because then I had some more context, had a little bit of understanding from their perspective of what the project would say, what I'd be looking for. So that was really helpful, especially not being a part of chemosensory research myself.
Are there any other questions? I did see that in the chat, Katie just posted a link to get to the promising practices directly from here. So you wouldn't even need to go to the STANA website. Although I encourage you to go to thestana.org. You can see all of our old newsletters, everything else there. Any other questions?
I'll just, while we're waiting to see if there's any other questions, I'll just mention that we have on this last slide, we're going to keep having conversations about patient engagement. And one of the next upcoming conversations is at the ACHEMS 2025 conference. This is an association of chemoreception scientists. It's the sort of largest gathering in the US of all of the researchers who are focused on chemosensory research. And the day before the actual meeting starts, there's going to be a day on patient-centered discovery and research implementation. One of the nice things that ACHEM has done this year is to create a new patient advocate rate. So it's a lower registration rate than others, and that they've done in the past. This is a completely new rate. And by signing up for the registration of the conference, it also gives you a 1-year membership to ACHEMS. So they've wrapped that into that rate. So that's really quite a good deal for patient and patient advocates. And as I said, this is sort of the preeminent organization. Now, unfortunately, it is only an in-person conference. So there is the added cost of travel to Florida, which we recognize a lot of people can't do. There's not a virtual option this year. We are going to have some STANA representation there, and so we will certainly summarize what we learn and come back to our community with that information. All right, I think if there aren't any, do you see any other questions come in?
I do not. No, I don't think so.
Well, thanks. We'll just thank everybody for your participation tonight and for joining us on Anosmia Awareness Day.
Yes.
Thank you, everyone.
Thanks. Take care.